look forward, Dr. Jünemann, to your talk. Thank you.
Das. Yeah, Ms. Isling, thank you very much. Franz Recker, thank you again for inviting me again to TRUS. It's a beautiful day today, and it's a fantastic meeting. And don't worry, I discussed all the critical points with Mr. Barons already a couple of months ago in Moscow, and it's really fascinating what he is doing. But the question is, do we really have to rely on MRI, or can we still use our transrectal ultrasound system? So the question what Peter Hammerer and I have to, or the task we have to fulfill is to tell you something about recent developments of transrectal ultrasound imaging, and I'm talking about the histoscanning. At the last AUA, that's about 3 weeks ago, the Heidenreich group presented a paper on histoscanning in repeat biopsies of the prostate. He showed quite disappointing results. A total of 61 patients, 834 cores. The detection rate was 25%, and for the course it was only 5% in his study. The sensitivity was 30% around, specificity 73%, negative predictive value 93. The problem with the whole thing is, and that actually came up also in the discussion, is number one, he says that histoscanning has no beneficial effect in prostate cancer detection. His problem was that the specificity is difficult to detect in a transrectal ultrasound screening program because you don't get the prostate. You don't know if you just missed it. And that's always the problem when you calculate the specificity in any kind of device, in any kind of imaging tool, because you don't have the prostate in your hands, and so you don't know if you missed it, yes or no. The second is that the whole calculation is a little bit strange, because when you recalculate it, you must end up with the positive predictive value somewhere around 50 to 60. Anyway, they were not able to answer the question because, unfortunately, Mr. Eplin became father the day before, so he was not present, and I hope that Axel Heidenreich can clear the situation in the future. What was the problem, or is the problem with this study he presented over there? The problem actually was basically answered by another paper that was presented at the EAU in about 3 weeks ago in Paris, and that was presented by a group from England. And they showed actually a concept of detecting prostate cancer by transperineal sector biopsies. And as you can see over here, they divided the patients in 2 groups. Patients with a prostate size of 0 to 30 cc versus those bigger than that. So the smaller prostates received 24 cores, the other ones received 32. And this was the concept that was behind it. It was a very interesting paper. And what you can see is they had the following patient groups: prior negative TRUS biopsy, they detected 174 patients. They upgraded from previous detections 63, and an anterior lesion in 11 patients. Active surveillance, 350 patients, 112, that's 1/3, was upgraded by this type of biopsy, 23 in the anterior area in the apex of the prostate. 29 they detected after radiotherapy, 2 were in the apex, primary, 153 they detected, and of course they had no previous histology of those patients. 11 were in the anterior lobe, and restratification 69, and 5 were in the anterior region of the prostate. The overall detection rate per se was something around 53%. That is quite good, actually. If you compare this with normal transrectal ultrasound guided biopsies in the literature, we have detection rates between 24 to maybe 35, but then you must be really good in order to detect the right or the cancer within the prostate. So what does histoscanning actually mean? Those of you who have never seen the machine, I just explain it very quick. You have actually an ultrasound machine, and it's preferably the BNK ultrasound device, and you have a little handle and a motor-driven handle that actually rotates the ultrasound probe within the rectum of the patient once it's fixed to the patient. And then you have a calculating system that incorporates an algorithm that calculates where the prostate lesions are. So what you do is actually you perform a transrectal ultrasound as you usually do, and it takes about 5 to 10 minutes, or even 3. I don't know how long it takes in your hands. And then you perform the histoscanning that still needs around 30 minutes that in order to get the right templates and to see and calculate and actually analyze your results. So why does histoscanning calculate the raw acoustic signals? Well, the reason for that is that because what you believe you see is not always what is true. And in other words speaking, sometimes you think that the prostate looks normal, but overall, and all of a sudden, you see that there is something inside that might be prostate cancer, that might be prostatitis, we discussed it already, or it might be ASAP or high-grade PIN. So the interesting thing is, and that's all the system and the concept behind histoscanning, that various prostate tissues have identifiable acoustic signatures. So actually they look different, like in the MRI system. So at a certain point you can say if it's more dense tissue, it has a different signal in comparison to a normal BPH gland, for example, where you have other problems, for example, when you look at the acoustic signature of these tissues. And then, of course, these acoustic signatures are very unique within the prostate because of their physical characteristics, irregular growth, vascularization, purely defined boundaries, and, of course, variable stiffness of the tissue per se. So the histoscanning algorithm has been trained using this extensive histopathology in order to differentiate between the various types of tissue, and then actually to show you these. And I will show you an example, one of the first ones from our group actually, because the software changed in between, I think, 3 times already, and you will see the difference while I'm going through my presentation. So this is the prostate gland. And then, of course, you say, well, everything is pretty much normal, and then all of a sudden you see something like this. And the lesion is not this one over here, because we call this is the red banana. And the red banana occurs because you put too much pressure with your ultrasound probe from the rectum against the prostate. This is the interesting lesion, and this one, of course, is also in the transitional zone, where you can probably detect prostate cancer. It was cancer in this patient, of course, but what you only can say it's cancer suspicious, as you will see, according to my data I will present you in a minute. What did they do once they developed the histoscanning system? I told you that they used histopathology and, of course, the raw signals, acoustic signals from their ultrasound machine, and they compared. They put a grid over all these cross-sections, and they compared actually the ultrasound signal with each slice of this prostate. So this is the cancer lesion, and it was, of course, marked by the pathologist. And then, of course, you have a full size of the prostate, all of the slices, and then you actually look into your data of your transrectal ultrasound system, and you look, how does the signal look like in this area? In comparison to this area, to here, and there. And from this, they came up with a histoscanning signal. So in other words speaking, if the histoscanning signal picks up a signal that looks like cancer, then of course it shows as red. And that's what you see over here. And once you click on this red spot, then the whole system measures it automatically 3-dimensional. So you get it a cross-section, you get a coronary section and a length section. And out of this, you get the 3-dimensional picture of your prostate. The first paper that had been published on this by Breckman and co-workers, he actually looked into patients where they did, prior to radical prostatectomy, a histoscanning. And the overall results were that the sensitivity was, in lesions, they were equal or bigger than 0.2 cc, which is pretty small, 95%. Or if the volume was above 0.5 cc, it was 100%. The positive predictive value, as you can see, comparable to the MRI. But again, the problem is you have to differentiate between screening and the situation prior to surgery, as you will see later on. This is from our first study we did, and these were our demographical data as well as our results. So these are the PSA values, and the volume of the prostate is more or less comparable. And what we found were in 44% it was recurrent biopsies. We found prostate cancer in 43% and no prostate cancer in 45% of the patients. The indication for the prostate biopsy was PSA above 4, or digital rectal examination was suspicious, or the PSA velocity was above 0.75 nanogram per ml per year. We took a maximum of 3 different areas which we identified as suspicious within the prostate with the histoscanning, and took 3 biopsies from each area. If we only saw 2 suspicious areas, of course, then we took 3 biopsies from 2 suspicious areas. And then we did it perineally, targeted, and we did it transrectally, targeted as well as saturation biopsy. So we compared all of them, perineal, transrectal, and transrectal saturation biopsy. That's how the system works. We do it with a template like the brachytherapy. I have a special template. They actually also calculated and made it for me, B&K made it for me within the system so that I can use bigger needles. So when I do the perineal approach, I use a 14-gauge needle because the pathologist has a much easier life when he has bigger cores in comparison to the 17-gauge one. This is the situation. As you can see, this is a cross-section. You see the lesion over here. You see the longitudinal section, so it's in the front part and the apex of the prostate. And of course, this is a coronary section again. Right in the middle of the prostate at the apex, you find the lesion, which is in the 3-dimensional picture at the apex, and you can see it over here. This is probably an area you would never, ever biopsy with a transrectal ultrasound system. Never, ever. And it's interesting. I learned a lot because many, many of the lesions we see are right located in the middle, in this area, or even at the base. And then, of course, you look where you are, and then you do, we call it Schifferversenken in Germany, and you put in your needle just at the area where you want to hit the tumor or the suspicious lesion. Once you have done this, you change the probes, and you're done. You do your normal transrectal ultrasound targeted biopsy as well as the saturation biopsy. So what about the perineal targeted versus a systematic biopsy? With the perineal biopsy, we actually found altogether 69 of the positive ones when we just used the 17-gauge needle. We compare the 17-gauge needle with the systematic transrectal ultrasound guided biopsy. And with this one, we found it in 62. So we were not so bad, actually, with the transrectal systematic and saturation biopsy. So there was a 7% difference. When we compared perineal targeted versus systematic biopsy, and we also included all needle sizes, then we found quite interesting results, because we see with the perineal approach, we found the tumor in 88%, and with the systematic one, even not so bad, in 79%, which is quite good. So actually, we were quite okay with both systems, except that we only need maximum 9 biopsies, or took maximum 9 biopsies targeted in comparison to 14 with the systematic one. So the difference was 9% for the 14-gauge versus, what was it, 7% with the 17-gauge. These 2 groups occurred because at the beginning we used the 17-gauge needle even for the transperineal approach. That's why you have those 2 figures. So the perineal and the systematic biopsy together allow more prostate cancer detection. The perineal biopsy detects slightly more cancers which are not significant, not at that stage. We are calculating right now our current data. We screened about 1,000 patients so far and took biopsies from about 200, and it's under calculation right now. So the 14-gauge needle has a benefit. It hits more areas, particularly in the apex of the prostate, and we think, at least our pathologist is happy with it, that the 14-gauge needle is an advantage in comparison to the 17-gauge needle. So when we compare the perineal targeted with the transrectal targeted biopsy, then you see a significant difference, because just with the perineal approach we found 44%, and with both, or the second one as well, plus 50%, so 94% were detected with the perineal approach, and with the transrectal approach, only 56%. So when I come back to the first slide of the presentation of the Heidenreich group or the Aachen group, I believe that they missed a lot of these cancers because they only performed their transrectal ultrasound biopsy with the targeted approach, as you can see over here, and 56% is no better than the normal transrectal ultrasound system probably can do in an experienced hand. So when we compare both the needle size as well, then you find with the perineal approach 95%, and with the smaller needle in 92%, there is a minor improvement. It has also something to do with courtesy to your pathologist, so that he has an easier life probably. And but when you compare to transrectal approach with the targeted biopsy, it's only 56%, so it's significantly less. Conclusion number 2. The perineal targeted biopsy is significantly superior to the transrectal targeted biopsy. The 14-gauge needle is slightly better than the 17-gauge needle. And of course, it's questionable to talk about the role of the targeted transrectal biopsy. We still perform it, but we just do that in order to fulfill the criteria we need in order to have an excellent calculation for our statistics. But I'm pretty sure that within the next 1 or 2 months, we will skip the transrectal targeted biopsy in histoscanning. Actually, what I will do in the future, I can tell you even right now, is just doing perineal biopsy, and that's the way to go in the future. So what about the quality of histoscanning? Does histoscanning detect prostate cancer? And remember the presentation of Mr. Barons. He has the same problem as we have, or we have the same as he has. Because in 35% we found prostate cancer. This from all of our people who do the biopsies. Premalignant lesions we find in 20% and prostatitis in 30%. You may improve these data with the experience of the one who is taking the biopsies, but even myself, I am close to 50%, it's 48%, it's 15% over here, and it's still 30% with prostatitis, and it's only 5% of no cancer at all. So the conclusion number 3, the perineal core biopsies can detect more prostate cancers in the maximum of 3 versus 14 locations, and the premalignant lesions make about 20%, and prostatitis is 30%. False positive results, overall, that means even the residents who are taking the biopsies are included, is only 15%. So we also wanted to know how good is histoscanning when it comes to surgery. We did it also prior to surgery, as you have seen with the MRI study. We compared, of course, the pathological result with our histoscanning results. I just show you the figures. And the figures even improved because at this calculation, we only incorporated 17 patients. Then we recalculated it with 50 patients, and the figures improved again. At this stage, we had a sensitivity of 0.81, so we were correct with the right localization in 81%. With the 50 patients, we were at the right localization at 89%, which is close to 90%. So we are close to the MRI, and we will get to this point. And the sensitivity was 0.46 for the normal transrectal ultrasound, and it improved to, with the 50 patients, to, I'm talking about 3-dimensional ultrasound, to 57%. So basically, you can say that the histoscanning actually allows you correct localization of the prostates, which is around 90%, and this is basically more or less double what you can see with your normal transrectal ultrasound. And you compare with the Barron study, they found actually the cancer lesion in 57 or 56%. So we are more or less at the same level. Mark Emberton presented at the last AUA in Washington last year a paper on 27 patients where he also performed histopathology in the prostate and divided it in sextants, and the histoscanning sensitivity was 0.9, pretty close, and the specificity was 0.72. So actually, there are not only one who is talking about these results, there are at least 2 who actually have this experience. So what about work in progress? What's the next and what we are working on? We know that we are not really fighting against MRI, but we want to keep the prostate in the hands of the urologist, of course. We are working on a robot-navigated puncture device, so that not the urologist is doing it any longer. It's an automated system that is doing it. It's called RONAP. And it's an excellent, helpful thing for targeting tool for focal therapy. For example, if you do we are part of the TOCAT study, so that we actually do the photodynamic therapy in those patients. You detect the cancer lesion Also, we have to compare it also with MRI. And then you actually stick in your needles, you inject the substance, and of course, the substance is just killing the cancer in this area, and the rest of the prostate stays alive. This is something for the future, but actually we will face and see more and more of these studies, and I believe that histoscanning is a tremendous helpful tool in order to have really get to the point that we have focal therapy in the near future. Our next step is differentiation of signal quality to even allow a more precise puncture site. And this is something very surprising to me, because we have this already, and we're testing this for the company, for AMD, and it's not really available in the software right now. And I said, does it really help me? Just to see where I have the best signal. And the best signal, and this is the three-dimensional picture of it, is always where you have the green spots you can see over here. And it's very interesting. So far, we have it now for 3 or 4 weeks, this new software. I punctured, where I have the histology already, 8 patients. And out of these 8 patients, 7 were positive. I don't know if it's really depending because we have this new software, or it was just coincidental. And when I have done 50 or 100, then I can say more. But it's interesting to see that you actually hit exactly this area, because before that, everything was green, and you didn't know where to take the biopsy from. And then you get the prostatitis, then you get the high-grade pin, then you get ASAP. We have not so much trouble with puncturing something that shows nothing. So as I said, we have actually a detection rate of something that is pathological, you can say, in 95%, which is pretty good, I would say. But this actually was the problem, because I always said we never have seen so many ASAP or high-grade pins as we saw since we are doing histoscanning, 20%. I don't know if you know your data. If you have 20% of high-grade pins and ASAPs in your patient groups, this is very unusual for us. And I believe because we always punctured these areas, and now we are close to get closer to this point. Mark Emberton, he actually says he is even a little bit further with a new software, because he's working on tissue characterization. He showed that on 3 patients so far at the AUA last year, and he can differentiate between Gleason 7, Gleason 8, and more. And this is interesting. If this is possible, it would be perfect. So my wish, and actually we are working on this with AMD, is I would like to see prostatitis yellow, high-grade pin orange, and cancer red. Thank you very much for your attention.
Thank you very much, Dr. Jünemann. I think we'll go on with the next talk, and then we'll have the questions, because we need to move ahead. So we'll have now Peter Hammer, and he will tell us about elastography. Thank you, Peter.
Where's my presentation? Yeah. Good. Okay, was mache ich hier? Abbrechen? Okay, good. Well, dear colleagues, it's a great honor to discuss with you elastography of the prostate. And when we talk about imaging, actually, we have to ask ourselves, where are we standing? We heard very nice lectures about MRI, but I would like to bring you back to our urological tool, and this is transrectal ultrasound. Well, you've seen pictures like this, and especially in transition zone cancers. These are cancers which are missed by transrectal ultrasound. And we all know transrectal ultrasound is not perfect. This was a recent paper. Transrectal ultrasonography guided biopsy does not reliably identify dominant cancer. Well, is elastography the answer? There are many papers, and I would like to discuss with you the pros and the cons of elastography. Chris, you still do transrectal ultrasound? Sure. What is this? This is transrectal ultrasound.
That's post TURP status.
Very good. Okay, that's easy. What else do you see?
Black stuff at the top, that's the liquid.
Yeah, that's
And posteriorly, I see on the right, on the left side, a little nodule.
Okay, good. You're good. That's a hypoechoic lesion, and that's the corresponding elastography. And elastography measures firmness. blue is hard, hard is bad. So when you look at this, you say, well, there are many blue areas, but here, this is the cancer area. So it's very simple. You measure firmness, hard, dark blue, cancer. Okay. Well, you have seen, pictures like this. This is the history of elastography, and, these pictures look very strange, but they're getting better. And this is what we can see right now. And these are some of the publications from the last years. When you look at sensitivity, it's between 60 and, of course, there are always some people, they say they're around 100%. Well, this was a paper from the Hamburg group, George Salmon, 109 patients, sensitivity 75%, specificity around 77%, and positive predictive value and negative predictive value, I think they are okay. This was the latest publication I could find, published 3 months ago, a small series, and when you see the results, they're very comparable. So you can say these are good results, these are bad results, but they're very consistent. And, well, it's not so difficult. Again, transrectal ultrasound, and you may say, well, I already see the hypoechoic lesion here. And it corresponds to the dark, firm area, and you can biopsy this, and this will show you an aggressive prostate cancer. These were our series when we looked at patients who had negative biopsies. And, well, we found high sensitivity, specificity between 60 and 70% in our series. And when we do the biopsy, we can use the ultrasonography image to really put the needle in the area which looks suspicious, and I think it's really helpful. However, there are limitations. And what are the limitations? Well, first, prostate size. If you have a man with a real big BPH, it's quite difficult to, get real good image, especially from the transition zone. Chronic prostatitis and calcification, that's difficult for the guy who's doing the elastography because you measure firmness. And if there are many calcifications, forget elastography. Tumor volume, I think that's a pro. We don't want to identify small tumor volumes, and elastography doesn't identify these very small areas. Posterior tumor localization may be a problem. And of course, we do have a long learning curve. Well, I looked in PubMed regarding learning curve. Is there anything I could find? And this was the only paper I could find. It's not from urology. It's from Hepato, from the guys who are doing liver ultrasound, learning curve and intra-observer reproducibility, evaluation of liver stiffness, measurement by transient elastography. And I found this very interesting because the conclusion in this article was liver elastography requires no learning curve. The novice is able to obtain a reliable result after a single training session, whatever the professional status. This may work for gastroenterologists, but not for urology. In urology, it's really different. You really need a long experience, a long learning curve to really get reproducible results. So what is the future? Well, maybe we can combine it with contrast agents. We do fusion with MRI images. And there are some papers looking at fusion MRI images with transrectal ultrasound. And this was one of the recent papers published in the Journal of Urology. And this was the paper. Unfortunately, the results didn't show up. That's already my last slide. Regarding elastography, I think really it's an improvement for the detection compared to grayscale ultrasound. There are promising results for rebiopsy, but there's always a but. It's dependent on by the investigator. There is a long learning curve. And I think that's the most important point. We do not have large prospective multi-institutional trials so far. There are some cooperative studies, and I hope we will have these trials in the future to really see what is the value of this urological tool. Thank you very much.
Thank you, Peter. Well, we'll have 3 quick questions and then we'll have to be over because we are very late and our chairman is a bit worried. And I understand him. So, who wants to go ahead? All those ultrasound images are well known to all of us.
Who is doing elastography? Oh.
Well, then I have a question to Dr. Gräfen. What do you do when you have a suspicion of an anterior lesion, when you want to go ahead with, you know, elastography? You're sort of dead with an anterior lesion, or what's your attitude?
I think so. So you have quoted our study from Georg Salomon, and the downside of that study was, for example, that is done in patients who had confirmed prostate cancer. So there's a lot of limitations on those data you presented. Anterior lesions, you usually don't see that. You need MRI, I think, for that. And maybe same with HistoScan, I don't know.
We rarely see anterior lesion. We see some, yes, but most of, I mean, I don't know if you miss them. We have to go back into our data and look if we find additional anterior lesions. But our problem is not so much as you have, for example, with the prostate size, because then we do 2 or 3 scans, and we can calculate it and recalculate it again. The problem is later on when you want to puncture it, if you really can see and find the area where it was positive, because you have 2 different sets of sites, you can say. And I think this is the only problem I see. Otherwise, it works perfect in our hands at least.
But I think with the transrectal ultrasound needle, you can reach any area in the prostate. So I think this is not a limitation. You know, when people say, well, you cannot reach this area, I think that's wrong. With my needle, I can reach every area in the prostate.
I don't know. I have my doubts. I have my doubts.
I think we'll discuss that around the coffee. Yeah? So we'll be back here in 15 minutes.